Hi, welcome to the SRG Paramedic Academy, and today we're going to spend a few minutes with Dr. LaGrave. And this is the first of a series of podcasts that we intend on doing through the semester with special guests. Each one will provide some information about practices and about general tips and tricks and ideas that will be highly related to your ability to practice as a paramedic, especially within the healthcare system and as well as the public safety system. So, as most of you are aware, Dr. LaGrave is the program medical director. And how long have you been the director here at the JC?
This will be my eighth academy.
Eighth academy,
Yes,
so
sir.
8 years, and has managed to live through two program directors and has seen a change in the program and while under his command. And as the medical director in accreditation, he's responsible for the oversight of the quality and the content of the medical education that you receive. And it is considered to be an essential part of any accredited program. So we're super pleased to have Dr. LaGrave as part of our team. In Dr. LaGrave's other life, he's the assistant chief of the emergency department at Kaiser Santa Rosa. So you'll see him out there once you go to the clinical piece, and I know that he's looking forward to seeing you. We're especially fortunate because unlike many other programs across the country, we happen to have somebody who was a field paramedic and spent some time in the field, both as a air medical service flight paramedic through REACH locally, and prior to that, his experiences was as a street EMT and a street paramedic in San Jose, California. And I think that really helps to inform Dr. LaGrave in terms of what paramedics can do in the field. So welcome.
Thanks for having me here today, Mr. C. It's always a pleasure, and I always am inspired by how talented all the folks are at the JC Training Center for all the different public service entities, and I'm happy to be here this morning.
Oh, that's great. Thank you so much. So we're going to talk a bit about the assessment process because, as it is with any primary care practitioner, it's your assessment process that really sets the tone for everything else. Don't you agree?
I completely agree. I think that for our paramedics at the Santa Rosa Junior College paramedic education program, I've always focused on the fact that they need to understand that part of what their job is to understand what's going on with the patient and what needs to be done. They're simply not there to pick a patient up. They need to understand what's going on and what they're going to do, and it's important they have an assessment that's strong and helps them get through that process.
Yeah, I agree. I think that what differentiates, we always have this discussion about technicians versus clinicians, and it isn't to say that technicians are bad and clinicians are good, but there's this underlying tone about, a technician sort of operates off of protocols or operates simply by it. I see what I have and I respond to it, and that's all that I do. And that the clinician does something a bit different. Would you want to talk about that a bit?
Sure. I think that's a really important point. And one of the things that paramedics graduate into is the sense that they have a broader scope of practice, but also that their job is to use their clinical experience to help guide care, not simply follow a protocol. The assessment that I use allows me to keep my differential diagnosis broad, and it allows me to think of all the different things that may be happening with my patient and then come up with a good plan that's going to allow me to capture the information I need, keep people safe, and start their treatment. And that's different than someone who's simply a rote technician.
Yeah. So what do you think it takes in order for somebody to get to that point? So here's the typical EMT that gets, about 150 hours worth of training, and they're basically designed to kind of look for signs and symptoms, maybe get a sense of what's happening, and implement a relatively limited treatment plan. How does one transition from that to becoming a clinical paramedic?
That's a really good question. It might seem silly, but first of all, they have to know that that's the expectation. The expectation is not that you're there to gather data, collect vital signs, treat a symptom, and transport. The expectation is that now, as a paramedic, you're thinking broadly, not only about assessing the scene and the safety for you and everyone involved, about the patient and how their complaint relates to an underlying pathology. But you also have to know that it's the expectation that you're thinking broadly about this patient and all the different things that may be happening, and that your job is not just to collect data, but to actually think your way through the issues to make sure you come to the correct conclusion. And that's very different than just a technician who's collecting information and reporting back. So first, know the expectation is that you have a broad differential diagnosis and a strong assessment to get you there.
Okay, so you just mentioned the word differential diagnosis. What does that mean? So what should a paramedic think about when you say, as a doctor, hey, what's your differential diagnosis on this patient?
So this is great. I love this part of the lecture when we get into the concept of a differential diagnosis. So once again, please know this. I love it when I'm in the classroom at the beginning of an academy and I ask a question about chest pain. And I'll give an example. An 18-year-old, tall, skinny, athletic kid playing basketball develops chest pain suddenly. And I tell that paramedic class, what is your differential diagnosis? Mm-hmm. Maybe one or two will raise their hand out of a class of 20 saying, differential diagnosis? Mm-hmm. What is that? This is very important. A differential diagnosis is a list of things that you think may be happening with the patient that you have to be ready to treat, with the primary thing you believe is going on at the top of that list. Let's say pneumothorax. But the differential includes pneumonia, acute coronary syndrome, costochondritis, chest wall contusion, any of the things that may be happening with that patient, but you have to keep in mind what the main thing is, but just keep it very broad. The other important point of a differential diagnosis is this: it's always open for question and reassessment.
Mm-hmm. I think that that's excellent. I think that, again, from a perspective of a field provider, we have a really limited scope of what we could use. We don't have labs, we don't have x-rays, we don't have other diagnostic tools to help guide our differential. But we take a history, we do a physical exam, we have the luxury of looking at the environment and talking with family members or witnesses that would never show up at a hospital. And that's how we sort of create this story. And the idea that we simply just take bits and pieces of information and we apply a protocol to it, that's what it seems like at the surface. But really underneath, there's a whole lot more that's going on.
That is a great point. And I want to make a point about something that you just said that's important that our paramedics know and that makes the paramedics stand out. And I make this differentiation for them, is that when a paramedic comes in and they have a broad differential and they're thinking about the overall patient and the assessment and all the different things that are going on, they shine. It's really clear that that paramedic is thinking about this patient and not just delivering information. But more importantly, we really do listen. And in today's hurried emergency department, when a solid paramedic comes in and tells me they're concerned about acute coronary syndrome, then it really helps me to focus and it helps push that patient ahead. Yeah, you might not have access to a chest x-ray or to labs or to a CT scanner, but when the seasoned paramedic comes in and tells me they're concerned about something on their differential diagnosis, they are dramatically helping that patient, dramatically helping the medical team that's about to take over, ensure we don't miss anything on that patient.
Oh, I think that's great. And I think that again, as being part of the healthcare continuum, we're often at that front end piece. And I think that there is that expectation that goes on with folks. When we hand over patients, there is an expectation that we should have a sense of what's happening with that person with us and what our suspicions are. I think that's key. So in terms of some of the finite pieces of the assessment, so as a physician, when you walk into that examination room, what is it that what are the key points that you think about, either consciously or subconsciously, that drives your assessment?
So this is one of my favorite things to do, is when you first walk up to a patient, is to think for a moment. So what do you feel? What is your clinical gestalt, or the clinician's feeling about what may be happening? So a key point is, what is the general appearance of the patient? What's your initial instinct? And what we like to call in the field, as you well know, big sick versus little sick. That's coming in from across the room. You walk into a scene call for a chest pain patient and the fire department's there and things are happening, you can see as you walk up if that patient looks cyanotic, diaphoretic, ill-appearing, or if they look well and you think you may have a minute here to get things started. So general impression is a big part of my initial assessment.
Okay.
The second thing would be, is I just want to make this point, is that my assessment has been groomed over many years, but I still use the same basic assessment. It's really important that I use this as a tool, and the reason is I don't want to miss anything. And if you do something in a strict, systematic approach, it's less likely that you'll make an error. You know, our medical field's trauma care is sort of built that way. It might seem a little redundant, it might seem like you're doing the same thing over and over again, but it really is designed in a large volume of patients not to miss anything. So be systematic in how you approach your assessment.
Okay. I think it seems. I think at the very beginning, when you're learning about paramedicine and you get all of these snippets of medical conditions and trauma conditions that are thrown at you, that it's easy to think, well, I have to sort of adapt my assessment. It's got to be different for every different patient. But the reality is that would totally get you lost very, very quickly, and you'll miss things. You'll lose things. You'll cover things twice because you don't have a consistent pattern to that particular approach. So I think that point is particularly important. What do you think about history taking? Are there any tips or pearls that you could provide somebody in terms of when they struggle to figure out, well, what questions should I ask? How do I get to the meat of the matter quickly? Is there anything that's in your toolbox that allows you to do that?
So that's a thoughtful question. I also just want to reiterate what you just said about the assessment and how it's pretty amazing, isn't it? How your same basic assessment can be applied to different scenarios, call after call after call. But if you have a solid assessment that you rely on, you'll be able to catch anything in any given call. And so that's very important. And I agree about looking at the medical history. The medical history is a big component of your assessment because it'll help to guide you, and try not to get lost in all of the different complex medical conditions and the changing scenarios and all the different scenes you'll find yourself in. When you have a strong assessment that you rely on, you can make your way through any of those things. With the medical history part, what becomes important is that the paramedic also has the skill not to labor in the past medical history. Just last night, I had a very kind, thoughtful, energetic 16-year-old girl who from birth had congenital heart abnormalities. She had ventricular septal defects. She had coarctation of the aorta. She had a pacemaker put in at the age of 8. And she came in at the age of 16 last night for syncope. Could be a very complex thing. Well, do you think my past medical history guided my care? Well, it sure did. So as I heard her history, I see 16-year-olds with syncope quite often, but very different when I stopped and asked, do you have any past medical history? And when I heard that significant past medical history, I did two things. One, I didn't languish in it and spend the entire hour just talking about her past medical history, but two, it helped focus me on the cardiogenic component of syncope and why this is important, as I kept my differential broad about what may have caused her syncope. So past medical history, very important part of my assessment. Just don't languish there too long. Get the important information, help it to focus you, and then move along.
So to sort of finish that piece out, sometimes students, so we teach them the basics like OP, QRST, and sample, right? Those are really constant, consistent mnemonics that they learned in EMR, then in EMT and paramedic. And I think for some paramedic students, they feel like, oh, that's just so superficial. But there's a reason why we ask those questions early, right?
Absolutely. So I hate to sound like they're not important, or maybe I have some higher level reasoning or skill as a physician, but I have to tell you, from my EMT class, every night I still use AEIOU tips. I use PQRST. I use a sample history. They're part of my assessment. They're thorough, they're practical, and they'll help me to be very effective in gathering history and helping to kind of broaden out what might be going on with my patient. I tell you, anytime someone has pain, the first thing that pops into my head is, Tell me what happened. What's it feel like? What provokes it? So those are tools. They're a component part of a strong assessment. Please use them and know that they're part of your armamentarium of things you do with your assessment to help you gather history. I tell you, one of the fun things for me is when I have one of the paramedics in the clinics with me while they're doing their short stay of time in the ED, and we go in and we see a patient who's altered, and I say, tell me what you think could be going on, and they're blank because they're in this ER and it's busy and there's these machines and monitors and there's a sick patient. And then I say, well, could it be alcohol, insulin, overdose, trauma? And I go through AEIU tips and the light goes on. It is a powerful tool. Use those mnemonics.
Perfect. I think that's terrific. And do you have anything else that you want to add to this particular podcast before we sign off?
Yeah, so first of all, just thanks for having me here today. I just love being the medical director and engaging with the paramedics, especially at this stage. I think the educational part is awesome. So thank you. Keep up the good work too. I think the Santa Rosa Junior College is great. But in terms of the assessment, there's no hidden mystery. This isn't Hogwarts. I have a basic assessment. I rely on it constantly. An assessment is a tool that you use. You could use it in your clinical practice. You can use it today in your personal life when you're choosing to make an important purchase. The assessment for me is something I use, and I focus on doing it the same way over and over again. Just like when I look at a 12-lead EKG, I look at it, I have 5 or 6 things I look for in the same pattern, the same way, so I don't miss something important. As you grow and develop and start barking like a dog because you're happy about assessments, then practice your assessment, focus on it, and talk to me if you need some more information on it. I use it every day. Thank you, Mr. Sia.
Thank you, Dr. LaGrave, and we will talk to you all next time.
Have a great day.